Hopefully, what I plan to focus on today will be of broad interest. Don't be persuaded by the title that this is some narrowly focused presentation on ADHD. Indeed, as someone who's swallowed the RDoC Kool-Aid, I can say that overall there's implications from what I'll be talking about for the treatment of kids, adults with autism and related disorders, and honestly a wide variety of pediatric or early onset neurodevelopmental disorders. But this particular group of studies and results do revolve around ADHD per se. So what I'm going to review with you today, and we have the luxury of ample time. Hopefully, because I am a Texan, I do talk rather slow. I apologize for that. But we should have more than enough time to cover the material. I'm going to talk about the scope of the problem of ADHD as it's usually defined, briefly describe to you, which you're probably painfully aware of, that it is a serious disorder despite some of the controversy about its validity. And I'll tell you a little bit about how it impacts kids, teens, and adults. Talk some about its natural history, the current approach to its treatment, the impact of the treatment of ADHD with medication specifically, and where unmet need exists in the treatment of ADHD. And then I'm going to show you how we responded to this information and the challenge about perhaps improving treatments for ADHD with some research that we did, and kind of give you a whiff of both the challenges and opportunities represented in taking on something like improving treatment, as well as what the future may hold. Now, of course, the criticism of ADHD as a valid neuropsychiatric syndrome is that everybody has a little bit of ADHD, right? Well, that's partly true in the sense that the behaviors that make up the core symptomatology of ADHD are found in the entire population, and indeed are fairly well normally distributed, as you can see here. This is from a study done over 10 years ago by a close colleague of mine, Sue Smalley at UCLA, making use of a very, very cool birth cohort study in Finland, the Northern Finland birth cohort study, which had enrolled 2 successive cohorts. This particular one represented all births in northern Finland, if you just sort of draw a line truncating the middle of the country, in the year 1985 to 86, which represented about 6,000 kids. Their mothers were poked and probed during pregnancy with all kinds of biological sampling and data obtained. And then they've been followed now for some 3 decades. Well, Smalley had the opportunity, collaborating with the Finns, to, in some of the planned reassessments over the years, at their 13 to 14-year-old visit to obtain some data on behavior, including her special interest in ADHD. And this is just using a simple parent-completed SWAN questionnaire, which basically takes all of the cardinal symptoms of ADHD and then rewords the question so that you can be low on certain symptoms as well as high. And it yields this kind of distribution, which is in fact almost normally distributed. Now, what Smalley also showed is that within this large community population, this isn't being drawn from a clinic or anything that would perhaps skew the characteristics. If you just look at those kids, 13 to 14, who are rated by parents to score in the upper 10th percentile, and then drill down and look at the characteristics of those kids, sure enough, they look just like the kids that you're diagnosing in your clinic, I'm diagnosing in my clinic with ADHD, and they have all of the associated baggage and features like oppositional defiant disorder, increased, learning disabilities, increased, early engagement in substance or alcohol use, poor academic achievement. So indeed, yes, it's true, ADHD symptoms are common, but when you look at this behavioral extreme, you're capturing a special group that indeed behaves as a disorder with a predictive phenomenology and in fact predictive course in response to treatment. It is true that there have been some secular trends in the rate of diagnosis of ADHD in the United States, and at various points people have raised alarm about how doctors and maybe drug companies are promoting its diagnosis and just to make a buck to sell more medication. The CDC has been running annual and repeated surveys of children's health and other surveys in which they've queried on things like ADHD. In their 2007 National Survey of Children's Health data set for kids 4 to 17, they asked parents with a household survey, has your child ever been diagnosed with ADHD? 9.5% said yes. When they came back about 4 years later, that prevalence rate, if you will, had climbed to 11%. I mean, in some respects, you may not be impressed with going from about 10 to about 11, but if you sort of multiply that across the population, that's a lot more kids, right? It's almost 15% increase, or 10% plus. So there is some evidence that diagnosis is increasing. But others have taken stock of this issue and really wanted to try to figure out, is there a secular trend? Is there something pernicious that's taking place in the environment, in our society that might indeed suggest that ADHD is increasing in our population? And the larger efforts, both this meta-analysis and a meta-analysis by Eric Wilcutt, published about the same time, took every single epi-prevalence study they could find, put it all together, and instead of a rising line of estimates of rates of ADHD, you can see it's pretty flat. And it represents a little over about 7% of child and adolescent populations if you take all of these studies together. So a little bit of reassurance on the one hand that maybe, at least if you're approaching diagnosis as a researcher, applying rigorous criteria, screening kids all in the same way, you end up yielding about the same rate. Now, in practice, in communities, there may be other factors that lead to possible over-identification, as the CDC data suggests. So it's hard to know what's going on there. But overall, at the very least, we can say there's not evidence that rates of ADHD are strongly increasing. A separate but important related question, especially for you clinicians and parents and family members in the audience, is the extent to which doctors are indeed overdiagnosing and overprescribing relative to the prevalence rates of ADHD in the population. So again, I'm sure your memories are sharp. You remember exactly in the 2007 CDC survey, 9.5% of parents reported an ADHD diagnosis. In 2011, that was at 11%. Anybody want to guess what the rate of medication use was in that 2007 survey? How much? What rate or percentage were treated? Yes? 34%. Well, you got the main drift. 4.8% of the same parents reported that their kids with ADHD were receiving medication, so about half. Far less than many, I think, even of us might predict. And certainly in the lay press, with a lot of discussion about, our pill-popping society and the ease with which doctors reach for their prescription pad rather than other interventions, maybe would lead you to assume that the prescription rate or the treatment rate would be higher. And indeed, in 2011, while the rate receiving medication had gone up a little bit, it still suggested that there are a lot of kids, almost half, that are not receiving at least one of the forms of standard treatments for ADHD. I find it kind of interesting, again, given the controversy that exists around the diagnosis, around the use of medications for ADHD. Now, of course, that doesn't mean that all the kids that are taking medication need it, nor does it mean that medication treatment alone is sufficient or always is required. Quite the contrary, and I'll come back to that in a minute. If you then put it into context in the US, that means that there are indeed several million kids in the United States taking stimulant medications on a daily basis, probably around 3 million kids in the present day. Okay, so why am I here to talk to you? I'm here to describe to you the challenge of what ADHD represents relative to our standard treatments. Now, even this premise is kind of interesting to me because, like, if you go to a lot of very prominent adult psychiatrists or pediatricians and kind of ask them about their priorities of what they really want to fund or what they think researchers like us need to focus on, ADHD doesn't come up very much, really. The presumption is more along the lines of, hey, for that one, we know what to do, thank you very much. We can take care of that. We need to work on autism, we need to work on schizophrenia, et cetera, et cetera. I certainly don't argue with those, but what I'm here to say is that the glass is definitely half full, but half empty with respect to what we're doing right now, today, with all of our best efforts to treat ADHD. Okay, what leads me to that conclusion? I mean, if you looked at some of the major, the seminal treatment studies in the literature on ADHD, you would come away with a pretty darn positive impression. So in this left panel here is the first 14-month results from the landmark MTA study of ADHD. Those data were published in 1999, a 6-site national study funded by the NIMH, which took kids between the ages of 7 to 9, meaning ADHD diagnoses, couldn't have Tourette's, couldn't have depression, so a little bit cleaner group, had to have normal IQ, and randomized them into 4 different treatments. The first group was, hey, you made it, you're eligible for the study, but we're going to refer you to community care, sorry. So treatment as usual. Second group was medication only, with some differences between how community docs prescribe it, but just methylphenidate, just Ritalin only as the treatment. The third group was randomized to behavioral treatment only. And boy, this was the Lexus of behavioral treatment. more than 15 hours a week of behavioral intervention, including both development of token economies that could be transplanted into the kids' classroom, to family treatment, to some educational intervention. I mean, it was a nice intervention if you got randomized to that. And then lastly, the fourth group was the combination of the medication plus the Lexis behavioral treatment. There were 6 sites. 3 of the sites were directed by the nation's leading disruptive behavior experts, behavior therapy experts, people like William Pelham, that you might have heard of. The other 3 sites were run by the leading child psychiatry pharmacotherapist in the field of ADHD. And as you might imagine, there were some diverse opinions about what the best treatment might be. So in that way, this study was super important in informing us about that. What did they find? Surprise, surprise, that top solid line is the treatment as usual. In actual fact, about 2/3 of those kids got a medication, most of them stimulants. But those community practitioners didn't do quite as good a job as they could. So that showed the least amount of change or decrease in ADHD symptoms, all the way though to 14 months after starting. The dashed line right beneath it, not significantly that different, was the Lexis behavioral therapy only condition. Hugely disappointing on the face of it to those 3 site directors who thought they could equal or almost equal the medication or the combo condition. And then equally surprising was this 3rd dash line that you see here. That was medication only, no parent training, no school-based classroom management involvement. That was just probably the best prescribed methylphenidate or stimulant only that you could cook up. That was distinctly statistically and clinically superior to the other 2 treatments, the treatment in the community, the behavioral treatment, and it almost overlapped on most of the major ADHD symptom measures with the combo treatment. I mean, wow. Think about all of the effort that went into creating this fantastic combo treatment and the added cost involved, and how much greater improvement was eked out of that. Not as much as most people would have predicted. So anyway, that forms a hugely important kind of empirical basis for what many doctors do. That said, there's been many reanalyses of these data. And if you look at enough variables, indeed you'll find that in some areas the combo treatment did emerge as being superior to the medication only. It depended a lot on even the family structure of the child's environment and other kinds of problems that they may have had. And I'll come back to this as the standard of care, but in incorporating both elements from both behavioral intervention as well as medication are considered the standard of care now. And even if you study ADHD in Sweden, use a different drug, you get what looks like to be solid improvement in many areas that is robust and maintained over time, above a year. So what does this mean? We can knock these symptoms way down. Doesn't it seem like then we should be successful in mitigating the bad longer-term outcomes of ADHD? You would think so, right? But what happens to ADHD over time as children grow up? Does it go away because we have these great treatments that at least half of them are getting in the community? No, it's doggedly persistent. It's a very stubborn condition. There's many ways that this has been looked at, but the rule of thumb that we train our little child psychiatry residents is that about half of those kids diagnosed in childhood will show so much improvement that they no longer meet criteria for the diagnosis by the time they turn about 18. And the other half, though, will have pretty persistent, or at least impairing, ADHD symptoms. Truth of the matter is, even those who are more fortunate, that 50% who get a lot better as they get in through adolescence and young adulthood, a lot of them complain bitterly about still having some isolated problems in attention or impulsivity, enough so that they report it causes problems in their life. So anyway, now what's also interesting though about ADHD, if you look at it over the lifespan, is that it does sort of morph with age and development. And in this one study, they looked at kids diagnosed with and without ADHD, and they divided it into the three common diagnostic categories. Some kids just have the concentration problems, the inattentive subtype, right? They're pretty well behaved if you were just like watching them in a classroom. Other kids, particularly little preschoolers, are wildly active and impulsive and aggressive, but it's a lot harder to figure out if they're really not paying attention. And then the combination, of course, is attention problems, hyperactivity. If you go into the community, you might think that it's the combination subtype that's most common, but actually not. It splits out almost equally between combination and inattentive only. So we miss a lot of kids who are just inattentive in the community. But anyway, this was a longitudinal study that tracked this 300, almost 500 kids over the course of many years from childhood into adolescence, and just looked at what categories they stayed in when they were retested or reassessed later on. You can see there was a lot of movement within the different ADHD categories, and a lot went from combined to inattentive, for example. And it's true, fewer came out with a diagnosis. Some 43 kids ended up without a diagnosis that didn't meet criteria early on. So some are improving enough to lose the diagnosis, but the vast majority continued to be impaired and have quite a few symptoms. Likewise, kids with ADHD, as they grow up, prove to be vulnerable to a whole host of other kinds of behavioral and learning and psychiatric problems, as shown here. In a way, you could conclude that ADHD is a universal risk factor for most forms of psychopathology. It certainly behaves that way. And you can see that there are pretty high rates of these co-occurring diagnoses, and including, interestingly enough, conditions like anxiety disorders or depression turn out to be pretty common, especially in adolescence and adulthood. Now, it's a mistake to think that ADHD simply exerts its impact on academic performance. In fact, parents will report to you that it impairs the quality of life in just about every domain, even physical health, where they have more doctor visits, their annual medical costs are higher than kids without ADHD. But it's important to recognize that this is a disorder that has a pervasive impact that sometimes isn't fully appreciated. That's another reason for thinking about how can we improve treatment. Let's take a closer example of one domain within that, the social impact of ADHD. You might think of a cute little second or third grader with ADHD as being like the life of the party, that kids would gravitate to them because they're very energetic, they're sometimes kind of provocative or interesting in that way. No, it doesn't work that way. So this is from a small summer treatment study that was done by Stephen Henshaw and colleagues a while back. And when they looked at a group of kids, some with ADHD, some were typically developing. They brought them into this summer treatment program, which was packed full of fun and also some like mock classroom stuff and other multiple observations of social activity. And from the get-go, they did interesting things like they just showed pictures of the other campers on the first day and had the other kids rate their likability and stuff like that. And then they repeated that at shorter intervals. This was a longer interval in which they had the kids rate how much they liked other kids and the number of friendships with other kids in the camp that they did or didn't have. And lo and behold, in this relatively short period of time, in just a matter of weeks, the ADHD kids, far fewer friends, many more had none or no friendships or kids that they considered likable compared to the comparison group. So already you could see this sort of trend towards being isolated, rejected, being lonely, gravitating perhaps to the wrong peer group. So not good, not good. And most of these kids in the ADHD group had been diagnosed, had been receiving treatment prior, so it's not like they were just completely untreated either. So as far as the standard of care for ADHD in the US, we know a lot. We have a solid evidence base, as I showed you a couple seminal examples of. But it's very clear that despite the strong evidence supporting medication, and some would argue the equally strong evidence supporting behavioral and classroom management approaches, that the typical child in the United States is undertreated for their ADHD, especially so with respect to their receiving behavioral or family or classroom management interventions. Fewer than a quarter of such kids in the US on various annual analyses of things like Medicaid and private insurance data show that they've received any therapy for ADHD of any kind. And we saw from the CDC data that the rate of medication use is even lower than the prevalence rate. So there's undertreatment with medications as well. But the common practice is to consider a comprehensive approach utilizing multimodal treatment, as we saw with the MTA study here. So again, if you looked at this on its face, you would say, wow, with the best treatments, you were reducing the severity of ADHD by greater than half. If they were starting out with a mean symptom severity of 2, and they're knocking it down to about 1, home run, right? Well, let's check out what the investigators themselves said about that study. They concluded that in many respects, the benefits were limited in some key areas. Academic achievement, you would think that especially like the combination treatment would help those kids kind of catch up relative to their peers in terms of their learning and academic attainment. No, they got a little pop for about 5 weeks, but then their rate of learning did not further accelerate. Socially, how'd they do? We know they get rejected much quicker. Only 2 out of 18 measures showed admittedly modest benefits. And one of the key researchers from the Pittsburgh site, Betsy Hosa, said, it's of clinical concern that even these high-intensity long-term interventions had limited influence on the peer problems of the studied children. Okay, there's a big part of the challenge, right? This same MTA study has been following up obsessively their subjects now for 12 years, when they published a few years ago the results of their 8-year follow-up of these kids. Not that they've been consistently treated, but just to look at their outcomes. They had some results as shown here. They continued to follow a comparison group of kids without ADHD. And man, the ADHD subjects just didn't get that much better in all of these various domains of quality of life that we already discussed. Here's one example. This is just looking at inattentive symptoms. These are the community control kids. They were pulled from the very same classrooms for each subject. So every ADHD subject had a comparison kid drawn from the same classroom. So really nice control. But I mean, look, even with that treatment, knocking down symptoms, it's still like double the severity in the just typical kids. How about like with something like learning, math achievement scores following up over 8 years? Guess who the dash line is? That's the controls, right? Do the ADHD kids catch up? Because a lot of doctors tell parents, hey, this goes away in adolescence. They don't seem to be catching up much from an endpoint like that. So why is this? Why do we have this profound discrepancy, you might say, or incongruity between big effects on symptoms, but limited effects on what you might call real-world outcomes? And I think it's important to pause for a moment and say, this is not different from autism, for example. This is not different from childhood OCD. We can move symptoms, we can reduce symptom severity, but it doesn't always mean that the real-world adjustment follows to the same degree. So we can improve these ADHD symptoms for sure. And if you just study like the response to the standard prescribed drugs over a course of maybe 2 weeks, 4 weeks, you'll be able to say, brag at the cocktail party, I can improve 75% of kids with ADHD in terms of their symptom decrease. And that's true for kids, teens, and adults. And it looks like, I mean, in the MTA, they track kids for 14 months. I mean, that's pretty durable treatment overall. And for the most part, there's no reason to believe that the benefits of things like medication wane over time. They remain pretty good. So that leads one to feel compelled to develop hypotheses about why it is we're not doing a better job in really pushing the needle further and changing the outcome of kids with ADHD. And so as a part of a big NIMH research center that we had a few years ago, we were obsessed with cognitive control, or those mental functions that underlie judgment, planning, inhibiting responses, things like that. So one hypothesis that we felt might be true is that maybe we're not doing a good enough job boosting cognition in ADHD. And maybe, yes, we can knock down symptoms, but maybe cognitive functioning isn't really improving as much, hence the still prominent real-world outcome. On a clinical level, though, there's another hypothesis that I think is credible and is still out there, namely that we don't treat hard enough to get to what one could call a remission of ADHD. We're too comfortable just knocking down symptoms significantly, but we don't go the extra mile to try to normalize behavior or get as close to that as we possibly can. There's reasons to believe that both are credible hypotheses. But because I'm surrounded by neuroscientists at UCLA, I mean, they're everywhere, we were fascinated with this cognitive control idea. And indeed, it's true that if you gather up a group of 100 kids with ADHD, even from northern Finland, like Smalley did, at least about 50% of them will have at least one prominent cognitive deficit. Things like that short-term memory, working memory, that initial kind of holding things in your mind so you can work on them and memorize them or manipulate them. Also, various measures of inhibitory control, or what some would see as an analog to impulse control. If you look at those two main domains, about half of kids with ADHD will score lousy on measures in one of those domains. And if you loosen the criteria for impaired functioning, it may be more than the 50%. But not all kids have these deficits. It's important to recognize that. And every kid with ADHD has a different cognitive profile. There are some subgroups, but it's not like there's one profile that's always attached to ADHD, if you follow me. These are pretty big differences as they've been described in the literature. That said, if you were a little one unlucky enough to have both ADHD and a cognitive control deficit, what we know about it is that you also don't grow out of that either. Your ADHD is very persistent. Your executive function or your cognitive control deficit is very persistent over time as well. And what does that mean? Well, these are the kids who've been shown to more likely need special education supports. They attain lower educational achievement and don't go as far educationally. They're more likely to drop out of school, things like that. So the addition of cognitive control deficit to ADHD predicts worse long-term outcome, and in that way, it's clinically very meaningful. Well, maybe you're not impressed with what I said about things like working memory deficits. We can learn to compensate for that, right? But it turns out things like working memory are just so critically important for all kinds of learning, as well as behavior regulation. In different studies that have attempted to look at things, in this case for math abilities, either verbal math reasoning or numerical operations math functioning, not requiring much verbal input. Working memory features large in that aspect of learning. Similarly, working memory plays a big role in influencing or underpinning reading as well. So it's kind of, its impact, if it's weak, is felt all over the place academically. And we and others have been interested in the relationship between some of these functions measured in a very narrow way, like with laboratory tests of cognition, with how these kids do socially. And even just looking at things from the child behavior checklist and measures of inhibition and working memory, we can see, admittedly not huge relationships, but significant relationships between things like working memory or inhibitory control and ratings of social maturity or peer rejection. And your own Megan Miller here had shown back in her graduate work that executive functions did show interesting and important relationships in girls with ADHD as they were followed over time although admittedly in a manner that was somewhat complex. But I think there is reason to believe from a number of studies, including Megan's, that this neurocognitive ability has a lot to do with kids with ADHD and how they end up over time, how much they improve, such as this study, which looked at working memory, for example, and reaction time, and its prediction of the stability of diagnosis and symptoms. So we wanted to take on this challenge of trying to cook up a way to further improve cognition, because there's a literature that shows that psychostimulants like methylphenidate do improve some aspects of cognitive functioning in both normals and in individuals with ADHD. And it's often assumed that those effects are really, really strong, really, really good. Indeed, there's even effects seen in other alternative treatments for ADHD, like guanfacine, as shown here, which reduced errors made in a search task in human beings. And often, if you look at these studies, try to take them all together, they're really a mixed bag, but you can find positive studies of stimulative benefits on working memory, inhibition, reaction time variability, sustained attention. But if you line them all up together and start counting which ones, or how many positives there are, how many negatives, it is more of a mixed bag than you might think, and the effects are not quite as strong. Likewise, for the alpha-2 agonists, these are drugs that act essentially by mimicking epinephrine or norepinephrine, increasing presumably arousal and prefrontal cortical function. You can see some benefits from the likes of people like Amy Arnsten and others, although they've been much better studied in animal models than in people. So we thought we were really smart. We came up with a hypothesis that, hey, we know that the noradrenergic system plays an important role in cognitive control. We know that dopamine function plays a big role in cognitive control. Hence, if we add those two treatments together, might we yield a more robust treatment wherein we might see even better behavioral improvement, higher remission rates or normalization rates, and better cognitive functioning. And that might be the royal road to improving outcome. So we set up as one study within our center a clinical trial of kids from 7 to 14 with ADHD, and we put them into this treatment trial. It was double blind, so nobody knew exactly what each subject was getting. The investigators didn't, the kid or the parents didn't. It was an 8-week study, a little bit complicated in design. We also did neurocognitive assessments in the middle, and at the end of the 8 weeks. And we also got repeated resting and activated EEG at baseline, 4 weeks, and 8 weeks. The actual study design looked like this. Day 1, kids were randomized to either placebo or guanfacine for the first 4 weeks. Then starting week 5, of the 3 groups, one group then that started on placebo added essentially Focalin or dextromethylphenidate. Another group that started off with guanfacine added a placebo, still guanfacine only, and then another group, equally in thirds, received the combination of the stimulant and the guanfacine. We also recruited a group of about 90 control kids, same age, tested them on all of these same baseline measures, and within those about 38 of those controls were repeatedly tested on cognition, mirroring the ADHD subjects. We reported the results of these three aspects of the study not too long ago, breaking out the results in terms of the symptom improvement, the cognitive change, and then looking at the EEG profiles. Participants were a fairly typical group of kids with ADHD, average age of about 10, normal IQ, just a little bit below the controls, mirroring a ton of other ADHD studies in the literature. More males than females, and controls were reasonably well matched overall. Diagnosed rigorously. We excluded autism, we excluded other severe forms of psychopathology. And it's important to note that about 40% of the ADHD kids had the inattentive only ADHD, okay? So, how well did our SMART idea work for symptoms, first of all? Okay, we were hoping for a little bit more, but we did win, showing that the combo treatment was superior to the other monotherapies on inattentive symptoms of ADHD. As you know, there are 9 different inattentive symptoms, and we showed that with both statistical significance, and I'll show you the clinical impact, that everybody improved. Guanfacine improved the inattentive symptoms almost identically to the dexmethylphenidate, and then the combo in the purple exceeded that reduction. If you just look at total symptoms, keeping in mind we've got a somewhat heterogeneous sample, the combo showed a strong trend, but didn't eke out victory there. And you can see that everybody got better overall. Now, the blinded clinicians did their ratings, and if you compare the week 8 clinical ratings, you actually see a slightly different pattern, a little bit more robust separation for the combination kids, because with the clinical global rating, you're taking information from all sources, from the kid, from the parent, and other sort of random things that you might be privy to. So guanfacine, it improved the ADHD in the majority of kids, but it was short of the stimulant, and the combo condition seemed to be superior. Now, what about cognition? That's a key domain, right? How did we measure cognition? Well, I'm also surrounded by neuropsychologists at UCLA. And if you talk to 10 neuropsychologists about, hey, how should I measure working memory? They'll give you quite a few different answers. But realistically, in order to test a stable construct like that, you do need to have multiple measures. You don't want to rely too much on just one measure, right? Dr. Schweitzer will tell you that, and others too. So our battery was focused on 4 major domains: working memory on top, inhibitory control in the middle here, and you can see there are lots of different ways to measure that. Some of these then are computer-based tasks, other are paper and pencil. This is more speed of processing. Processing speed being a really disabling aspect of ADHD if you have much experience with this group. And then what's called reaction time variability, which captures sort of the range of attention and its lapses, if you will. We did subject all of these tests. These were selected actually out of an even larger list according to a confirmatory factor analysis in which there was at least suitable modeling obtained, and these factors loaded on the specific domains as represented. So what did we find? Well, indeed, this was a group starting first with working memory. Here, we compared them in our analyses to the typically developing controls. And these are essentially effect size differences. So there's about a half a standard deviation difference between the ADHD kids and the typical controls. That's a large, clinically significant difference. It's a half of a standard deviation. So in that way, this mirrors other samples that have looked at the neurocognitive functioning in ADHD kids. How did our treatments perform? Well, you can see that for the stimulant and the combination, that those differences were reduced somewhat, almost cut them in half. Yay. But they're still relatively impaired. They're improved, no question about it. This is statistically significant in our model. But look at guanfacine. Now, this was a shocker because there's a lot of people out there with the belief that guanfacine and the alpha agonists are cognitive enhancers. We saw zip evidence of that in this study. And I find it hard to reject the data that we have. But what was perhaps more disturbing, we were pleased to see that working memory improved. And maybe we boosted it a little bit more with the combo, although it wasn't statistically significant when comparing the stimulant to the combo condition. When we looked at the other three domains, inhibition, reaction time, or reaction time variability, surprise, we did not see improvement in any of those other domains. The level of impairment relative to the controls was somewhat less, but still, relatively prominent, like effect size differences ranging from about 0.2 to mid 0.3. And the treatments didn't really seem to do a whole heck of a lot. Well, what I'd like to do finally then is to drill down just a little bit more into the cognitive results and show you, there are two main messages here. One is that it's a mistake to come away believing that we had a limited benefit on cognition, but it also goes to show the complexity of the effects of these treatments. So our working memory task was this visual Sternberg spatial working memory task, and then a kind of a classic go, no-go attention measure is shown here. When we just look at, this is just computer only now, look at working memory accuracy, we can see evidence that with the normal controls up on top there, that really it's the combo condition that is the only one that shows much improvement. And indeed, the combo condition separated on this one endpoint from the stimulant only in the guanfacine. So, hooray. How about a measure of what you might call impulsivity, commission errors on that go, no-go test? Not a significant effect. Again, mirroring the movement or lack thereof of the inhibition cognitive factor, as you can see. The combination conditions seem to improve towards normals, but statistically this was not significant. Now, omission errors, this is kind of inattention in a way, missing a target. Here, the pattern was a little bit different. Both of the conditions that had a stimulant improved significantly and ended up much closer approximating to the performance of the control kids. So what you can see here is that there is, these cognitive functions are really complicated, and they don't behave in the same way to the same or different interventions. And this forms an important methodologic and conceptual challenge, I think, to this area of research. So the main takeaway, I think, at this point is that cognition is a thorny and challenging target for enhancement. But as I made the point before, I think it continues to be a hugely important one. And here, you know, we're pleased to show with this one measure, spatial working memory for enhancement, it looks superior with combination and with omissions as well. Now, the third arm of the study was an EEG, repeated EEG assessment. And here, admittedly, what we were doing was a little more exploratory. Sandy Liu, who led this part of the study, had done work earlier showing that higher theta to beta power ratio was commonly seen in ADHD, and that theta power was a strong correlate of stimulant response. And so we looked at the EEG patterns within treatment groups, and indeed there was a different profile of resting EEG power with each of the three treatments, which is kind of interesting. And even that the combo indeed differed from the stimulant only, as you don't need a statistician really, I don't think, to see that, right? And the guanfacine only was very, very different. And when Sandy drilled down even further, she found that, interestingly, there were some, within specific EEG spectral power frequencies, there were unique changes associated with the guanfacine, with the methylphenidate only, and the combination. And the combination indeed seemed to represent changes that moved the EEG more towards normal spectral power across multiple frequencies, especially beta and theta power. So why would you even bother to do the hassle of all of this? Well, we were interested in thinking about or looking for whether there's a biomarker of excellent change. And I can't really say at this point that we have found that, but one might make the argument and follow up looking at the pattern associated with the combo condition as representing a preferred electrophysiologic response. And indeed, there were correlations with the EEG power changes and performance on selected cognitive measures. So we learned a lot from this study. Another point that bears mentioning is we learned a lot about the individual variability of these little ones with ADHD. What I have plotted here is for every individual subject in the trial, all 200 plus of them, across the three conditions, guanfacine only, stimulant only combo, their ADHD symptom score pre and after 8 weeks. And you can see incredible individual variation with the response to the same treatment. And parents, clinicians see this all the time. In some ways, we're kind of used to it, but it's only when you kind of look at a mass of data do you appreciate how much variability there is with things like what we consider to be a standard, usually effective treatment. Some kids improve incredibly. I mean, this might be normalization down here, for example. But other kids, of course, some get a little worse, right? So the treatment variability to whatever intervention you're wanting to study can be expected to be huge. And the reasons for that are far from clear. So to summarize then, in our treatment study here, there was a lot to feel good about as far as the overall behavioral improvement. On cognition, there was a lot of variability, some evidence for improvement, perhaps stronger with the combination condition, but even that varied according to which test you looked at. And ultimately, the significant individual variability presumably has a lot to do with both the underlying cognitive change and symptom response. So improving ADHD treatments is important, and I hope amongst you trainees there, some of you will take this on as your lifelong quest. There's a lot of work to be done. You can have a great career focusing on this, believe me. But be forewarned, it's hard. It's hard to change cognition in particular. It's probably hard to achieve at an even higher rate of remission or normalization at the symptom level. Cognition, I think, emerges both in ADHD, just like it is in schizophrenia, for example, as a very important treatment target by itself. And hopefully, as we're learning much more about the basic science of these domains of cognition, we can get really, really smart about what may facilitate enhancement of cognition. Now, we followed these kids for an additional 12 months. But our sample doesn't have the power, the size, to be able to show that if you stayed on combination, that 12 months later, your academic achievement scores, your California standardized your STAR test scores would be better than the monotherapy. But somebody should study something like this, I think. And that may be true. And lastly, we all would like to be able to search for a reliable and robust objective marker of changing brain function that could help clinicians kind of guide and fine-tune their treatments, maybe decide to add a different medication or increase one, decrease another. We're not there yet by any means, but I think there is a role for this more elaborate kind of approach, and particularly to think of cognition at the same time that you and mom and dad are looking at symptom change. So I want to acknowledge my great collaborators there at UCLA, Sandy Liu, Bob Bilder, Jim McGuff, John Passantini, and our brilliant statistician who helped us make sense of our complicated data set, Catherine Sugar. So thanks very much.
That was great. Thank you so much. And I'm glad that you speak slowly because I think slowly sometimes. It helps. So my wife's a special ed teacher, and we always talk about our shared interests and things. But I was wondering from that perspective, have some of your studies involved teacher observations as well, and what have you learned from how well the treatment benefits show up in the classroom, and what do you think of using those other informants for this type of work?
Mm-hmm. Yeah, that's a great question. And I think all of us who do research in ADHD, I think Julie would agree that we highly value the reports of other important observers like teachers. What's really interesting about that, and obviously we kind of look to teachers to corroborate what we think we're seeing with mom and dad and what the clinician thinks he or she is seeing. But what's often interesting about comparing teacher reports to parent report is they don't always go together. You probably know that all too well, and it can be super complicated clinically to interpret or to integrate those. But what has been interesting also in some of the other treatment studies that we've done, for example, the NIMH preschool ADHD treatment study, where we did elicit teacher report and parent report, is that I came away believing that the teachers in that population were the far better observers and reporters than the parents. I don't have an explanation for that, but it seemed to be just with regards to the improvement as the dose of the medicine was increased and some of the ratings of side effects, that the teachers seemed to be really reporting something that was more consistent and somewhat less variable within each child. Now, the other thing, though, is that teachers and parents aren't really, the context is so different that you have to appreciate sort of where they're coming from as well. The teachers are observing the behavior of kids in a much more structured, rule-bound kind of environment. And so it's possible that they could miss some relevant treatment benefit or treatment worsening that might be seen in a different setting. So yes, ideally we want to include teacher report in all of our studies. It raises the difficulty bar some, and we try to help the teachers complete our ratings, but they're busy people.
I am a nurse that works with children, disabled children, and in an elementary school currently. I haven't really worked there for long, but I've made some interesting observations because I am concerned definitely with a huge rise in attention deficit just this year. But I'm also from an area where the firestorms hit pretty hard. So you can imagine the psychosocial at home is horrible with, what they're going home to every night. And I actually asked a group of kids today how many of them were concerned about going home tonight, if that stressed them out. And several of them raised their hands. And granted, I'm prompting them with, my question. But the reason I'm in the classrooms is because I'm doing a very small investigation of my own with heart rate variability monitoring. And trying to see if I can see any results with that. So it's actually a pretty good indicator, I'm finding, of who in the classroom. I don't know these classrooms very well, but I can go in there and tell immediately who's having issues with attention and not. So. Yeah,
what I like about what you're describing is that there are a lot of folks, including a number of the investigators here, who are very interested in wearable technology and how that can really benefit us in finding more objective measures of possible improvement or possible diagnosis or impairment. And there's no question that these measures of arousal and sympathetic nervous system output can be meaningful by itself.
Did you and how did you control for the dosages for guanfacine and methylphenidate?
That's a great question because it is sort of a vulnerability that we have as far as our results. So the way that the medication dose was arrived at is we followed what we thought was kind of like the approach of a usual clinician. So titrating low, then the second week increase or plan to increase to a medium, and then the third week to a higher, and then at the end of the third week, using blinded parent ratings, side effects, and the clinician ratings, we, two independent clinicians decided on what the optimal dose of that one treatment was. So like for guanfacine, we had the kids start with 0.5 milligram twice a day, plan to go to 1 milligram twice a day in week 2, and possibly get to 1.5 milligrams twice a day on week 3. Some didn't get up to that because of side effects, drowsiness, and so forth. But that's how we dosed it, and we used an identical approach for the stimulant too. So we started on week 5 with low dose, and there it was weight-based. If you were less than 25 kilos, you started with a 5 milligram Focalin, extended release in the morning. Then you would go to 10 and 15. If you were a little chunkier, you'd start at 10, 15, and 20. And then we would figure out what seemed to be the optimal dose. So in that respect, the weakness is we had no idea what the cognitive change looked like. And maybe we would have gotten better or different results if we were just dosing by the optimal cognitive performance. But it's just so hard to test that, every week in 200 kids for 8 weeks.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.